it's an adult child or a spouse, to really help them to kind of process through what they're going through and not to feel guilty about this stuff, how to cope with it better, how to give themselves permission to give themselves a break, to have a professional caregiver in there. And again, that's another whole lecture. But that's a big part of what a geriatric social worker would do in this situation, is to help you, the caregiver. And that's a big part of what we do in our company. So these are, again, I think I said it initially, this is not meant to make anybody feel guilty. This is the ideal. It's not impossible in any kind of relationship, whether it's dementia or it's a child relationship, or, so you do your best. And more importantly, you separate yourself from the situation as much as you can. So again, suggestions for coping with changed behaviors include trying to remain detached, do not become provoked or drawn into an argument, do not try to correct or convince around delusions or hallucinations. That's a really important one, and we talked about that earlier in our staff meeting. If someone's having a delusion and it's not distressing for them, we had one woman who looked in the mirror all the time and had this major religious conversation with what we think might have been God to her, and it was very reassuring to her. And it really calmed her down, and I remember saying to the children, don't worry about it. We're not going to medicate for that. Does she have any other distress or delusions or hallucinations? What's making her feel bad? And they were like, nothing. Okay, so you guys just go in the other room and don't listen to it if it's making you feel bad. But we're not going to medicate something like that. Yeah. And again, today we were talking about a gentleman. He's at home. I want to go home. What's wrong, Mr. Jones? I want to go home. The caregiver should not go, you're home, Mr. No, look. Here. He actually was taken out for a ride and redirected, and he was fine after that. And I think he came home and he recognized his home, and he's like, oh, I'm home. So he's, I think Dr. Freitag said it earlier, it's kind of getting into the pool with them. What is going on with him? What is the emotion attached to that? And sometimes we're not going to know the emotion, but we're going to try and use, and I'm going to go over that in a minute, a pleasurable event, or, we call them pleasurable events / activities, to redirect him away from that anxiety. Catastrophic events. Did I? No. Okay, there. A catastrophic event is an overreaction to a personal experience or event. This might involve them screaming, shouting, making unreasonable accusations, becoming very agitated or stubborn, or crying. This tendency to overreact on the part of the patient is part of the illness. Catastrophic events can actually get really bad. And that's why, again, what I'm going to describe in a few minutes is very important, because you don't want to let something escalate until it can be really catastrophic. We had one client who had a baseball bat. I would get calls from the caregivers constantly. They would be locked in the caregiver in their room, and he'd be banging on the door with the bat. So that was a really, challenging case, but eventually we were able to kind of figure out when he was going to start to escalate, what were those signs that we would see, okay? And in his case, he would get snappy, and, we'd start to see the escalation, and we'd try and stop it down here. Catastrophic events can be very serious. Fortunately, what's really interesting is I used to work in Los Angeles and in New York, and for some reason, I felt like we had a ton of those kinds of cases there. And I haven't had that as much in this area. It's an interesting phenomenon, but maybe the Bay Area, maybe the weather. Maybe we're less stressed, but it can be quite serious. And again, I have to say, luckily, I haven't had too many of those here. I haven't ever seen anybody get hurt, but it can get very bad. I had this one client who would pinch, and you had to really be careful, because she would just start pinching you and it would hurt. And that was just a behavior. That wasn't her catastrophic event. Her catastrophic event was a whole other thing. So protocol for averting catastrophic events. Step 1, be a detective and explore the environment for what could be causing the behavior. And we talked about that earlier, the antecedent. Okay, hold on. It's the first time I've used this. I want to let you know. So, okay. How do we do that? We have a behavior recap sheet. What do we do with this? It's for the family and the caregivers, any kind of caregiver. Because what happens is you can track what is going on, and what's more important is this. What just happened prior to that behavior? That's the antecedent, the trigger, the precipitating event. It's all of that. And this works beautifully. So I always tell the caregivers, you're going to be the detective. And they track this, and then we're usually able to find out exactly what's happening that causes the behavior. Mr. Jones looks tired. He has been up since 7 a.m. Okay, it's 12:15. He should have been down for a rest about 11:30. You know, I mean, again, they're experimenting right now with his nap time. Visiting nurse and PT visited back to back. There was loud talking with the caregiver. Okay, he started hitting that caregiver. So we've now learned to space the events out, and this gentleman lives with his wife. So she has hospice coming in, and there's a lot of activity in the house, and so it's the caregivers policing that activity and making sure that, first of all, the appointments are spread out, and that if people are in the house, there's not a lot of loud talking. And we often see when there's been a lot of people in and out, he gets agitated. And then it's easy for the caregiver to get off his schedule. He needs a schedule. I mean, this can go on and on and on, and I think you kind of get the point. But I'll never forget at NYU Aging and Dementia Research Center, I had part of my job, because I was actually the interventionist, was to go to the homes and meet with the families in the home and get a history and do an assessment and help them to start tracking the behaviors. Well, this one woman, complained, and I'm telling you, I swear, I think it has something to do with New York. This guy was like beating her practically. It was really bad. And they were drugging this man, and it was, getting to be too much. And so they joined our study, and that was my first thing, was to try and help figure out what was going on so we can decrease the medications. He went to a daycare program, and every morning, she had to be at work at a certain time. She was moving 350 miles an hour, getting him in the shower, getting him dressed. She was so stressed. I mean, I know I have young kids, and I have to get them out to school, and I have to get myself ready for work, and I get a call on call, And she gave herself an extra half an hour every morning. She had the caregiver shower him before she came home from work, so she didn't have to shower him in the morning. There's all kinds of things that she could change and do. And she just didn't think about it because she's stressed out. And sometimes you need somebody to come in and really take a look at these sorts of things for you. So I think, you can kind of see how this works. Okay, so, okay. Oh. Uh-oh. Okay. I told you this is my first time. How do I go back? I'm here. Okay. There we go. I remembered. Okay. Sorry about this. Again, I haven't done this before. Oh, hold on a minute. There we go. Okay. So it didn't work. I'm sorry about this. It's my first time using this. Let's go back. There we go. Okay, go. I was trying to do the fancy way. I could have just done it this way. Okay. So that's kind of what that behavior recap sheet is for. We bring these into the doctors when we go on appointments. Bring them into the doctors. They take a look at them, and they can help you to figure out medications, because sometimes, no matter how good of a job you do behaviorally, and this is really behavior modification, not that we're going to modify, not that we're going to ask the client to change his behavior. We're changing the environment, and that's affecting the client behavior. That's how we're modifying the client behavior. The doctor can then decide on what to do with the medications, because sometimes you have to use the medications. Psychotropic / neuroleptic is another name, but you have to use those medications sometimes. And it's very